The time is limited, so please start the talk and then we have the question later. Thank you.
I was trying to keep pace with the rain before. Now I'm going to slow down a little bit. Okay. Thank you so much. So we're going to talk about complex colon polyp. So majority of the colon polyps that we see in our routine practice can be taken care by most gastroenterologists. But when they become larger or when they're located in certain places, they are difficult to remove. And those are the polyps the gastroenterologists feel that they may not be able to remove safely. So they're afraid of bleeding, they're afraid of perforation. And so they try to send them to surgeons. Or they may feel that they may not be able to cut completely. So if you cannot cut completely, you're going to leave tissue behind. So cancer may appear in that area. So that's another reason gastroenterologists ask surgeons to operate on them. So these are complex polyps. As you can see here, this is a large one, a big one almost occupying the lumen. This is going on a fold. This has been cut 3 times before, still coming back with scarring there, and a polyp in the appendix going into the appendix orifice, and one on the ileocecal valve and getting into the valve, and very low in the rectum. So these are called complex polyps, complex for gastroenterologists to remove. So in such situations, options are surgeons, but surgery there's a little bit of morbidity associated, there is a little mortality associated, and then there is a cost. And in the last 10 years, advances in our ability to control bleeding and also close perforations have allowed endoscopists to remove these polyps safely. So if the endoscopist can take care of that, the colon is left intact. If not, they may require a resection. So what are the principles? So when you see the polyp here, this is the mucosa, this is submucosa, this is the muscle. And when you try to cut this polyp, there's a high risk for bleeding because of hitting the blood vessels, and there's a high risk of injuring the muscle and creating a perforation. So to avoid those 2 risks, risk of bleeding, risk of perforation, you try to separate the polyp from the wall by injecting fluid or submucosal cushion of fluid. So you separate the wall from the underlying muscle and blood vessels, and then you can cut it at a higher level. And once you cut, depending upon where you cut, you may decide to close it to cut down the risk of complications. So that is a way to remove polyps. This is snare resection or mucosal resection. Sometimes the same polyp could be cut after lifting it with a knife in one piece. That is endoscopic submucosal dissection. So here is an example of a large flat lesion, injected, lifted, cut, clean base, cauterizing the edge, closure, and then 6 months, 18 months later, nice clean scar with nothing coming back. So that is a successful outcome. So in order to set up a process, this can be done. Any endoscopist who gets the skills can make it happen. But endoscopists need the support of the institution and a lot of people to make it a successful operation. So it requires partnership with physicians who are not able to remove the polyp, what they should do so that you can have a good outcome, and the institution to put in the resources and the team that is trained to take care of these polyps. So here is my group. For those of you who want to know, this is Dr. Ron DiPino, the current president of MD Anderson Cancer Center. You see my mentor, John, and the rest of the endoscopy crew. And these are very special people for me. These are the ones who actually cut the polyp. I actually take the snare, but they actually cut the polyp. Don't you think so, Rangsan? We just deliver it, they do the job. So these are the endoscopy technicians, highly skilled, and when they are highly skilled, your operation goes smoothly. I really admire them. And this is where my polyp clinic is happens, or the procedures in the Lee Clark Clinic. And over the years, we have been able to help a lot of patients in and around Houston. And when I was talking about Galveston, this is Galveston Island. And a few outside Houston, and then a few outside the state of Texas that we helped. So what is it that you need to set up? You know, it's not just what we do in the endoscopy suite, but it's the whole operation. So when you have a relationship with a referring gastroenterologist who can only take care of polyps of a certain size and they want to refer patients larger than that, you should have a good communication with them and tell them what to do and what not to do. You want them to make sure that they take lots of pictures, a long shot, a wide shot, a medium shot, and a close-up shot, so that when you look at a picture, you can pretty much decide whether there is cancer there or not, because not everybody has the eyes to make that decision. And the second one is whether this is the polyp that you can remove or not, so that the patient doesn't have to go through another procedure and wasting of resources. The other thing is to mark the polyp. You know, if the polyp is there, you mark it a few centimeters proximal to that in the same plane, and not mark into the lesion that causes tethering of the polyp. And if they take biopsies, a couple of biopsies, because when they take a deep biopsy, the mucosa gets stuck to the muscle, and it makes resection very, very hard. What a simple resection that takes 10-15 minutes can be an hour, because somebody has taken lots of biopsies that cause tethering of the polyp. Few things that you don't want your referring gastroenterologist to do, to avoid. Avoid big biopsies, avoid multiple biopsies, avoid snare resection, avoid putting a tattoo into the lesion. These make the job very difficult. So, coming to referral, you know, it's very interesting as I see these patients. Patients can come and sit in front of you, and you may not have a report. You may not have pictures to figure out. So it's very important to talk to your team and the referring gastroenterologist to send details of the report with the pictures and pathology, so that you can have a conversation that is meaningful. Because the patient is making a trip to your unit, you should be able to say, this is a polyp that looks benign and I think I can remove it. Or I cannot remove it, go for surgery, instead of taking them through another procedure. When they come to the clinic, this is what I do. So I talk to them about the importance of split dose so that they have an excellent prep. If they come in with excellent prep, even if they have a complication like perforation, and you close it, you will avoid peritonitis and emergency surgery. So that is something very important. The second one is, I usually take them through my YouTube channel. If somebody has a cecal polyp, I try to pick a larger cecal polyp that I've done so that they can watch and they feel confident that I can take care of that patient. It's very important the patient to come into the procedure unit feeling good that you can take care of the job and also less stressed about the procedure. So this is, any of you saw that? And then we talk about the risks of bleeding, perforation. Unlike in the past, large polyps bleed during your procedure. Like surgeons, nowadays you really don't bother. You can actually take care of the bleeding without the need to send them to surgery. And even perforations can happen, but perforations can be managed and still the polyp removed successfully. And when you cut incompletely, that's the patient that you should worry about, because this patient can come back with cancer later on. So it's critical when you follow this path to make sure that you have excellent follow-up of the patients. There's no point in doing a procedure and then they've lost a follow-up and then come back with interval cancer. So let's talk about how a procedure is done. So the key thing is, I want you to learn about the pathology of different cancers and how far down it can go, and you can still cut. Fortunately, colon gives a little more margin than the stomach and esophagus, and if there is an intramucosal cancer, you're good. But if it penetrates this muscularis mucosa and becomes an advanced cancer, it's about 1,000 micrometers. Beyond that, if you cut, you don't know whether there's lymph node involvement, and requires those patients may require surgery. So something to keep in mind in terms of safety margin to cut for a complete cut. So let's talk about it. Say, for example, you have a polyp with a little bit of cancer there. Okay, the cancer is here. You don't know whether it is submucosal or not, how far down it's gone. If you do an en bloc resection, you can pretty much tell based on a well-differentiated cancer with no lymphovascular invasion and a depth of penetration of less than 1,000 micrometers, you can say that you had a curative resection if it is an en bloc resection. Same is with the ESD if you have clear margins. But if you do piecemeal resection, then the pieces cannot be put together, and then you may be stuck with sending that patient to surgery. It's a small percentage. In my practice, I don't do ESD. I wish I learned the technique. About 4% of my patients who have submucosal cancer with piecemeal resection, I had to send them for surgery. The other thing is, if you have piecemeal resection, depending upon the number of pieces you cut, these are the patients who can come back with a recurrence. So it's very important to follow them up closely. So what are the principles? So when you look at it, you do the inspection and you know whether if it is benign, and you know that you can cut completely and you can manage the complications, you can actually set up a program for large polyp resections. So let's talk about the steps in endoscopic resection. We have learned a lot from our Japanese colleagues. You scan for cancer, that's the first step. And there are certain features that put you at high risk for cancer. So rectum, type of the polyp, and then the type of pit pattern makes you think if there is submucosal cancer, and you should avoid that. It's not just the size. So here is a large polyp. You see this polyp going all the way from here to here. And as you scan the polyp, every area looks the same. Here, 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 everywhere. And that is a benign polyp. You can safely cut. On the other hand, this is another large lesion, but this looks flattened out and with the bulging folds, and that looks different from the rest of the area, and that's the cancer. That's one thing that you may want to avoid doing a piecemeal resection, and even ESD would be tough in that case. This is another medium-sized lesion, but as you can see here, this has become flat and smooth, and that again was a cancer. So you want to assess the lesion before you cut. Here is a small lesion. You can see it's bald, and that was a piece of cancer. So it's very important to search and figure out focus of cancer and avoid resection in that. The next thing is cutting completely. One of the problems in my own practice that I'm not able to cut is somebody has tried. This is a patient that had been tried with 2-3 attempts of snare resection before and caused tethering, and this has led to failure of resection. But recently, you could actually take care of these things with the use of a hot biopsy avulsion and still get rid of it, but this is the patient that you worry about recurrence. So next is, how do you cut safely? So there are several different techniques that people can use, to lift the lesion, to put the snare parallel to the wall, to use a squeeze, check for muscle entrapment, and then use a microprocessor generated cut, and then check the cut base for perforation. So let me show you here. So here is a cut. It's a clean, nice base, and then you go ahead and cut the next one, and then be prepared for bleeding. If this happens in large polyps, with a little bit of experience, you could avoid that. And then if you cut in some, especially with scarring, try to pick up a perforation if it were to happen, and take care of that with the closure. So let me take you through a case here. Here is a large lesion. And the first thing is we try to look at the surface pit pattern. You know, we cannot be perfect, but try to look for and see if there's an obvious cancer. And if there's no obvious cancer, you try to do injection to lift it up. And then you put a snare parallel to the wall and cut. And after cutting, you examine the base, make sure the base is clean and there's no deep resection. And then move on. If there's bleeding, you can easily control that bleeding with either a snare tip, soft coagulation. Michael Burke has done a lot of work from Australia on this. Or you can use a hemostatic forceps, control the bleed. So once you have a nice controlled bleed and you did a lot of resection, you always have to keep thinking where the wall is going, and you need to know the wall with snare resection. You don't want to entrap the wall with a snare, and that leads to a perforation. As you can see here, so the wall was going in this direction, and here it moved up. And in that case, you want to change the direction of snare to catch it from below up, as you can see here, to keep your snare parallel to the wall for a safer resection. As you can see here, the steps we are doing to have a nice, safe resection as the wall changed its direction. And then to the forwards, to the front side, it was hard to do. Then I used a water immersion technique to cut, and this is the end of the cut. So these large polyps take time. I took 33 injections, 24 resections, 2 hours and 4 minutes. It takes a lot of time to resect these polyps. And the key is when you resect at the end, you should examine the edge and the base to make sure that there's no macroscopic disease left. And then when you're submitting your specimen, the big polyps are the big sessile component is the one that you want to submit separately, because that's the area which is likely to have cancer compared to smaller areas, so that you don't miss that. And then you should be prepared for delayed bleeding. Large polyps have a high risk of delayed bleeding. So this is a patient who came back with delayed bleeding, and we tried to do with a clip. We were not successful. We tried to do with a hemostatic forceps. Again, it did not work, and then I basically ended up injecting epinephrine to slow down, and the bleed stopped. It's critical to follow them up very closely, and then you need to take time to do a good exam. So here is the scar, the long shot, as you come down closer, and then you examine every few millimeters with a high-def scope. Sometimes you may have to use a near focus function to really look for any subtle pathology. And then with narrowband imaging, and then maybe, if needed, a chroma endoscopy by spraying some dye. So I want to share some of our experience in the last 5 years. So we have resected patients who have had prior failed polypectomies. Here is somebody who had 2 or 3 prior resections failed. Here is one with a large sessile polyp that was referred for resection, or it's a sessile serrated adenoma. As you can see here, polyp, lift, cut, closure, scar. And here is a large polyp in the ascending colon that was cut. Fortunately, it came back as benign, and I had at least 2-year follow-up with a clean scar. So we had about 203 patients. 7 of them had actually had cancer. So we did not resect them, we sent them for surgery. And about 41, we could not safely resect because of technical difficulty going around that lesion, and we were successful in 77%. We had 7 complications, and some of them had cancer, a small proportion that required surgery. And recurrence rate is about 3 to 4%. So there are opportunities to learn. I'm sure the Asian Pacific group has been very active. They've done some fantastic work. Hearing the lecture from Professor Kitano at JDDW, ASC does some work. This is one of the best DVDs that anyone could actually look at, produced by Michael Burke, available from ASCE. And I believe the Asian Pacific group is also doing a lot of hands-on training that helps a lot of people get up to speed. And if somebody is interested, I put in about over 100 videos of EMR on my YouTube channel. And thank you.
Thank you. Thank you, Professor Raju. It's the excellent talk on the polyresection. Anybody have the question? So I start with just a question. You mentioned about the pit pattern, and somehow that's the big polyp, big size, is followed with the chance to be the cancer. And you mentioned about the pit pattern, and can I ask, what did you use to differentiate the lesion before you're doing the EMR? Using the NBI or chromoendoscopy or EUS to estimate the depth of the invasion or area is the cancer before you do the EMR, please?
So one of the things that I've started doing is maybe take at least 5 minutes as part of my procedure to scan the surface and looking for on white light and narrowband imaging. And now actually with the near focus function, it's actually made it a little better to really pick out. And second thing is, if I see an obvious flat area where you think it is cancer, I've not resected them because I end up resecting piecemeal, because with piecemeal, you always have to send them to surgery. So if it is an en-bloc resection that I could do, I try to do the en-bloc resection. But if it is a piecemeal and there's obvious cancer on the surface, I send them to surgery without resecting because I don't want them to have additional cost of the procedure, additional complications until they heal. The second one is that this 5% of the patients which actually lift, and you think that you got a nice submucosal cushion and cut, and you did not think they had any cancer on surface morphology, did come back with cancer. And because I do piecemeal resection, I'm obligated to send them for surgery. So we send them for surgery. Out of the 6 patients, 2 elected not to have surgery because they are also dealing with other cancers, and we followed them, and they did pretty good with no recurrence at least for 3 years. And the 4 who went to surgery, all of them actually, the lesion lifted, you cut it, and your cut surface looks like as if it's an ESD type of clean base. When they went for surgery about in the next 3 months, none of them had any lymph nodes, and the scar was negative for cancer. So there is a small price we pay when we do piecemeal EMR for these patients, because at least 5%, I tell them that, okay, if it comes back as cancer, we need to. In an occasional patient where you can do an en-bloc resection, 15-20 millimeter lesion, which lifts well, but surface feature is a little bit worrisome, I tell the patient that the outcome is going to be dependent upon what the pathologist finds. recently, just about a month ago, I resected somebody who has had 2 prior colon resections for cancer. Came back with a rectosigmoid lesion, and I resected, and it was an en bloc resection, margins, peripheral deep margins clean, but the pathology was poorly differentiated cancer. And the depth was at least the free space was more than 1,000 microns. It's still, from the resection point of view, it was good, but the pathology was not favorable. There was no lymphovascular invasion. But because of the poorly differentiated nature, we just had to send him for surgery. So when I look back, all I tell when I talk to the patients in the clinic, I'll do my best. My outcomes are about, based on the experience that I looked at, 75% that I could avoid surgery. 25% I cannot avoid surgery. So we started, just before coming here, I started looking at more than 20 millimeter lesions with EMR. And the number is again at 76% that I could avoid surgery. And it's also interesting that people have not caught up with studying the lesion. Once they see a lesion, they take a few pictures, they take a couple of biopsies here and there, and then get out. They should, by doing that, a cancer that could have been picked up right when the original exam was done, that opportunity was missed. So I'm seeing at least about 5 to 8% of the patients that come to see me had obvious cancer that was missed by the referring gastroenterologist because of not taking directed biopsies at the cancer. And sometimes I've seen where somebody had did a snare resection of whatever they could find. That comes back as benign, but they missed a cancer focus somewhere else. So I think we should educate people about studying, because especially when we have these high-def scopes, that they should use the scope properly.
Thank you very much. Any question? I think we are running out of the time. But everybody's still in here and with the hungry, I think. So thank you very much, Professor Raju, and would like to close this session. Thank you.
Thank you, Dr. Supakit. Ladies and gentlemen, we have a token of appreciation. May I invite Associate Professor Chanchai Sitipan, Associate Dean for Planning and Development, to present the token of appreciation for our speakers. May I invite Professor John Strolai, Professor G.J. Raju, and our moderators, Professor Rangsan Rernimit, Dr. Supakit Komvilai, on the stage, please. Thank you.